W. Edwards Deming was the early leader in the field of quality improvement. He said that if you cannot measure it, you cannot improve it. Hillside chose something that can be directly measured: length of appointment times. Although they never measured this before, what if they'd selected something that can't be directly measured? This might have included staff satisfaction, or patient satisfaction for that matter. Indirect measures can be used to monitor quality improvement. One way to do this is by using survey data that contain a numerical question asking people to rate their satisfaction or the friendliness of a process or other very subjective measures. By using the same scale before and after an intervention, the process can be evaluated in numeric terms. For many metrics, the simple act of measuring or keeping track of the measurement could be considered an intervention. The Hillside team needed baseline data in order to have a comparison by which to judge any intervention. First, they needed to determine how best to measure the completion of appointments. Since the team elected to use scheduled appointment time as a starting point for all appointments, this was fairly straightforward and could be taken directly off the patient's schedule. Recording the end time was a different matter, since the electronic health record didn't record this in any particular place. Two mechanisms of the provider recording the end time were considered. The first was when the provider is done with the patient. However, this wasn't applicable to all appointments because some patients required other interventions after the provider had left the room, such as immunizations or clinic-administered medications, repeated vital signs, or other information needing to be gathered for purposes of a referral. The other mechanism for providers to record the end time would be to record the sign-off time on a clinic note. This information could be pulled directly from the electronic health record. It is a recognized best practice for clinicians to complete clinic notes in real time as patients present. However, in real practice, this is often not done and was not the case for all providers at Hillside Clinic. The nurses recording the end time of the appointment was also considered. This would require a change in workflow since not all patients end their appointments with a nurse intervention. For those patients who do not require a nurse at the end of their visit, it's impractical to make them wait to end their appointment for a nurse to be available. One practical method of recording end times for appointments would be to have one person dedicated to checking the end times for each patient in the clinic. Based on the number of providers in clinic at any one time, this could be up to 20 patients per hour. Having the front office staff record end times for all patients seemed to be the most practical method for Hillside Clinic. This did require a change in workflow, however, as not all patients checked out with the front desk. A hybrid between the previous two methods was decided on, where one person was stationed near the exit to check out all patients, make follow-up appointments, and record end times for each visit. A concern was brought forth regarding whether a backlog of patients waiting to be checked out might occur. However, in reality, this rarely actually happened. The baseline data was not truly baseline, as there was a change in workflow just to make the measurement, but this change was not thought to have a significant impact on what is being measured and was a practical necessity in order to make the measurement.